Good evening, sir.
Good evening.
Good evening, sir.
Well done. Sorry, I've been really busy since even today. Okpako can relate better, but we'll start now. The topics are not so much, so we'll see what we can do with the little time we have. So we're going to talk about pterygium now, and Isaac, can you move the slide? Okay, first of all, we need to know what the conjunctiva is, because when you talk about pterygium, it has to do with a degeneration, a form of degeneration called elastatic degeneration of the conjunctiva. So conjunctiva basically is a transparent mucous membrane that lines the inner surface of the eyelids and the anterior surface of the globe, terminating at the corneoscleral limbus. What this corneoscleral limbus simply means is just a junction demarcating the cornea, which is the clear part of the eye, and the sclera, that's the white part of the eye. So that junction of demarcation between the sclera and the cornea, that's what we call the corneoscleral limbus. And it's basically supplied by the anterior ciliary artery, and this supplies to the bulbar conjunctiva. I'm going to, in the course of the presentation, talk about the different parts of the conjunctiva. So don't be worried when you hear bulbar conjunctiva. So anterior ciliary artery is supplied, it supplies blood to the bulbar conjunctiva. Then the tarsal conjunctiva is supplied by branches of the marginal arches of the lids. Next slide, please. And is innervated by the ophthalmic division of cranial nerve 5. So there's a picture. Next slide, please. Good. So this basically explains what conjunctiva is all about. It's just that I cannot move my good. Thank you very much. So where that cursor is, that's what is called the palpebral conjunctiva, meaning it's just lining the inner lining of the eyelid, either upper eyelid or lower eyelid. It's also called the tarsal conjunctiva. So it's like just a lining of the inner of the eyelids, either upper or lower, the inner part of the eyelid. That's the palpebral conjunctiva. Then that purple one is what we call the bulbar conjunctiva. That one, it's just lining the globe. That's the eyeball itself. So you can see that demarcation I was talking about, the cornea and the sclera. So that junction is the limbus. So it terminates just before, like 1 millimeter before the limbus. That's the bulbar conjunctiva. Then we have another type called the phoneal conjunctiva. What this basically means is that, okay, the palpebral conjunctiva lines the lid, then it has a folding called the fornix. It's just a folding before it lines the eyeball. So that's folding before it lines the eyeball. Yeah, just at that junction between where the cursor is. That's where the phoneal conjunctiva is. So those are the three anatomical divisions of conjunctiva. Let's go on, please. Okay, so what is pterygium? So pterygium is a triangular shaped growth that consists of bulbar conjunctiva epithelium, hypertrophied subconjunctival connective tissues, and it occurs medially and laterally in the palpebral fissure, encroaching onto the cornea. So what this is talking about is that what we call elastatic degeneration of the conjunctiva, particularly the epithelium of the conjunctiva. The conjunctiva has different histological types, the epithelium, the stroma, and all of that. So particularly the epithelium of the conjunctiva has this excessive growth, and this growth moves typically from the conjunctiva and encroaching like a crawling movement, or like crawling towards the cornea. So it can affect the medial aspect of the conjunctiva or even the lateral aspect, but the commoner one is from the medial aspect. And like I said, it encroaches onto the cornea. So it gradually grows. As it grows, it doesn't bulge out like a ball. Rather, it grows to progress and encroach onto the cornea. So next slide, please. Okay, so really there is no defined etiology for pterygium. However, there is both a degenerative and proliferative process, and there are risk factors that contribute to the development of pterygium. One of them, very important, is the environmental triggers, the ultraviolet light, and some theories say that viral infections, some viral infections can cause it, but majorly is the exposure to the ultraviolet light, in a condition like ours in the sub-Saharan Africa. We're exposed to a lot of ultraviolet radiation. So you see pterygium commonly in this location. There are other factors which cumulative DNA damages and all of that, but majorly is the exposure to the harsh environmental condition in our environment that contributes to pterygium. Next slide, please. And like I said, the ultraviolet, the dust, the wind, and all of that. And there's what is called the Terrigen Belt, which usually is around latitude 37 degrees north and south of the equator. It can be hereditary too, People with P53 mutations are predisposed to pterygium. So, of course, like we said, viral infections too. Some theories posit that can contribute to the etiology of pterygium, like the herpes simplex virus and the human papilloma virus. You can see the percentages there. Next, please. Okay, so what's the typical clinical presentation of pterygium? Like we explained earlier, it's a triangular shaped, or you may call it a wing-shaped fibrovascular. It has both fibrous tissues and the vascular component. So fibrovascular lesion from the conjunctiva. It may be primary or recurrent. Primary means, okay, this person is having pterygium for the first time due to no other cause. There are some people, trauma can trigger what we call pseudopterygium or even pterygium itself, but primary cause, as the word implies, primary, Then recurrent pterygium means that yes, this person had pterygium before, which was operated upon by excision, like pterygium was excised, and now the person is coming down with pterygium again. So it may present typically like that too, as a recurrent pterygium. And it has different parts. I told you it's like a triangular or wing-shaped distance. So if you imagine a triangle, you see that the triangle has a head, which is the pointed part, then the neck just in between the pointed part, and the body. So the head, the apex enclosed by a vascular cap, then the neck, that's the region between the head and the limbus, and the body, the portion overlying the sclera. So there's what is called Stoker's line around the head. Is a brownish discoloration, just like a cap on the head of pterygium. So the symptoms of pterygium may include redness of the eye in the case of what we call inflamed pterygium. Pterygium that is inflamed, you may have redness, but pterygium that is not inflamed, it may not really be red like that. It may be, well, since it's a fibrovascular lesion, maybe a bit red or pink, but if it's inflamed, it will be markedly be red. So irritations too, because it's not flat, because it's not really a part of the structure of the eye. You may have irritations, especially and foreign body sensation, especially when you blink. It's just a raised growth there. And when you blink, you may feel it more like a foreign body sensation, irritation. It may cause blurring of vision too, and is by two mechanisms. It's either it has encroached to the point of even encroaching onto part of the pupil, or approaching the pupil. It may cause blurry vision, or it may alter the shape a bit of the cornea. And when it alters the shape of the cornea, sorry, are you following? Can you hear me? Let it
Yes,
not be
sir.
that I'm talking
We
to
can hear you, sir.
myself. Okay.
Can hear you, sir. Thanks.
All right. Okay, so if it alters the shape of the cornea a bit by, it's sitting on the cornea, encroaching on the cornea and sitting on the cornea, it may alter the shape a bit and make the shape a bit irregular, and that may affect the kind of vision, because cornea contributes a lot to vision. So it may form what we call astigmatism and cause blurry vision. There may be itching associated with pterygium too. Next slide, please. Okay, so male to female ratio is more in males than females from studies. Usually in the age group of 20 to 40 years and the elderly, it may cause diminution of vision, like I said, through astigmatism. Forget about the rule against the rule. That's a complex and this thing is not for this, but basically just know that astigmatism can be caused by pterygium, which can cause some diminution of vision. Then there may be intermittent episodes of inflammation, which we have talked about. Then cosmesis, especially for the females, single females who have not married, who, just having that kind of growth in the eye, in a way may reduce bride price, sort of, because people may attribute all kinds of things to it. Oh, could it be infectious? If I marry her now, this girl is not fine. Look at the growth in her eye and all of that. So cosmesis is very important. So diplopia too. It may, there are a lot of muscles, about 6 of them, that controls the movement of the eyeball. So if the pterygium is adherent to, let's say, the medial rectus, in a way, it may cause restriction of the muscle. So when you try to move your eyes, you may have double vision. So that's the next slide, please. Okay, so pterygium is graded. There are quite a number of gradings, but so let me basically explain them and tell you the one that is most important for you. So grading is based on relative translucency of the body of the pterygium. So T1 is the atrophic type. You can see the episcleral vessels beneath the body. So what this means is that there are some vessels called episcleral vessels just around the sclera, between the scleral tissue and the conjunctiva. So if you have a pterygium and you can see those vessels, then that's T1, the atrophic type. Then you have T3, which is the fleshy one, and the scleral vessels are totally obscured. And why they are obscured is because of the nature of the pterygium. It is fleshy, so it has covered up those vessels, so you can't see them. Then you now have the T2, which is the intermediate, just between T1 and T2. When you compare T3, when you compare whatever you have there is the T2. And fleshy, it is fleshy, and usually in the young are prone to recurrence. Okay, next slide, please. Why can't I even control this slide? Chief Wakwako. He says it's only the host.
Okay, why you can't
control the slide like
why
myself?
you can't control it? Because I'm not sharing it. If it was that I was sharing it with, I'll be able to control it.
Okay, all right, let's continue. So grading can be by the size too. So it is graded 1 to 4. Grade 1, when it's just touching the cornea, I told you it's from the conjunctiva and it's encroaching to the cornea. So as it just approaches the cornea, that's grade 1. More of like just slightly beyond the limbus, the corneoscleral limbus, as I described earlier. That's grade 1. Then you now have the grade 2, which is midway between grade 1 and grade 3. So what is grade 3? Grade 3 is when it's up to the pupillary margin. You know the pupil, the space created by the iris, the black space, the space created by the iris. So when the pterygium encroaches onto the cornea and gets to the pupillary margin, that's grade 3. And when it crosses the pupillary margin, that's grade 4. And this is the type really that causes the loss of vision or the poor vision, the grade 4, because it's covering your view. It's through the pupil that light passes through, or visual stimulation passes through to get to the retina, from the retina through the visual pathway to the brain, and the signal comes back normally that this is what you're seeing. So if it's covering the visual axis or the pupillary axis, of course, there'll be no stimulation, visual stimulation going in for you to see. So this is the type that really, really causes poor vision. Next slide, please. Okay, so this is pterygium like I described. You can see it's coming from the conjunctiva, and this is, so we can call this grade 1, Then this other type ahead. Now, pterygium can, like I told you, it can be medial and it can be lateral. So in some people, in one eye, it may both come, it's like a double dose coming from the medial aspect and also from the lateral aspect, and kissing themselves at the middle. This is the very bad one. We call it polar cataract, polar pterygium. They are coming from the two poles. So they come and join at the center and they can virtually cover the eye. So this is the one we call polar pterygium. So please go ahead. Okay, so this is the grading I was talking about. If you see the diagram on the right, you see the different grade 1, grade 2, grade 3, grade 4. Grade 4 is the highest, which, approaches the pupil, covers it, and all of that, as depicted in the human picture there. The other picture, that's grade 4. So that's the grading. Next, please. So what is the treatment? Diagnosis, actually, before we even get to treatment, diagnosis of pterygium is mainly clinical. There's nothing like investigation and all of that. it's on the spot diagnosis, so there's no investigation and all of that. But of course, you are not just treating the eye, you are treating the human being. For example, if the person has what's it called, diabetes, for example, diabetic patients have problem with wound healing. So you would want to at least have baseline investigation, like fasting blood sugar or even glycated hemoglobin, and all of that, just to be sure that the sugar is well controlled. Because if you go ahead and do pterygium excision for the patient and the sugar is very high, it may lead to poor wound healing and a lot of complications may result from that. But aside that, there are no specific investigations for pterygium. So we move to treatment, and you can prevent pterygium from using what we call ultraviolet protective spectacles, just to reduce the amount of ultraviolet rays that enters the eye. There's no effective medical treatment. When I mean medical treatment, use of drugs for the treatment of pterygium. However, you can, like I've said earlier, and you can use eye drops. I told you irritations can happen, even itching can happen. So you use eye drops, tear substitutes, decongestants, lubricants to try and reduce all those symptoms before you plan the patient for the definitive treatment, which is surgery. So you can use many options like NSAIDs, diclofenac eye drop, nepafenac eye drop, ketorolac, and all of that. You can use low dose steroids. You can even use what we call immunomodulatory agents like cyclosporins, to reduce the inflammation, because you don't really go ahead and do surgery for an obviously inflamed pterygium. At least you give medications to reduce the inflammation, then you can now plan the patient for surgery. Next slide, please. So what are the indications for pterygium excision? If there is, in a symptomatic patient with recurrent irritation, redness, watering, and all of that, you treat now, the patient comes back again later, every time, very discomforting. It's an indication for pterygium excision. Then the visual needs of the patient. If the pterygium is covering the visual axis, like I explained earlier, or threatening even the visual axis, it can cause astigmatism, like I said. So it's an indication for removal, visual needs. Cosmesis, like I said, in a single female patient who is desirous of getting married and all of that. Cosmetically, pterygium excision may be good to eliminate or to remove stigmatization and all of that, and increase her chances, sort of. Then therapeutic. There are some growths in the eye that are similar to pterygium, like pingueculum, and even what we call ocular surface squamous neoplasia, like the what is it called? Conjunctival carcinoma, conjunctival papilloma, and all of that. Some of them, the growth starts as if they are like pterygium. You may actually be confused, sometimes. So you do an excisional biopsy. That's why they call it therapeutic. If, for example, is a squamous cell carcinoma that is just starting, let's say CIN stage, for example, and you excise it completely, and even what's it called? Take a healthy part of the cornea, about 4 millimeters away from the growth too. You would have like achieved, therapeutic intentions. So that's another indication. Next slide, please. Next slide. Okay, so the surgical options. The surgical options. Please give me a minute. Let me attend. Okay, thank you. Tafia, hello. Please, are you there, please?
Yes, I was here.
Okay, sorry for the interruption. That's
No
not,
problem, sir.
okay. All right, so where are we? Okay, surgical options. Basically, you do what we call pterygium excision. But the problem is this: if you do pterygium excision alone, I told you earlier, you may have what we call recurrent pterygium. It may come back. So if you do only pterygium excision without doing other things intra-op, you're going to have 50% of the patients having recurrence. Let's say you do pterygium surgery for 20 people, about 10 of them are going to come back with recurrent pterygium. So there are options, other options, basically, that we add to the pterygium excision to reduce that recurrence. Number one is pterygium excision with the use of with the application of mitomycin C, meaning you remove the pterygium, then you apply mitomycin C. Mitomycin C is anti-metabolite that, of course, that is used more of like an anti-cancer medication. But it has, because pterygium is a growth, fibrovascular growth, just like other growths in the body, it has been shown to like reduce the growth and even the cells that are prone to growth. So with the application of mitomycin C, about very mild concentration, 0.06 percent of mitomycin C, you just, after that place you remove your pterygium from, you just place a cotton wool soaked mitomycin C, place on it for like 3 to 5 minutes, after which you irrigate very well with about 50 mils of normal saline, because it's very toxic to other parts of the eye, to like the cornea. So you wouldn't want it to touch your cornea. If it does, it can even cause perforation, erosion of the cornea, and even cause perforation of the cornea. So you just place it at that bed, not on the cornea, but the main part of it, which is the conjunctiva and the scleral part. That's it. So that way you've reduced the recurrence rate, significantly. And this is up to 95%, success rates. So you also have other options like the use of 5-fluorouracil, which is in the same class as mitomycin C, but mitomycin C is more available compared to 5-FU. So we use mitomycin C more than the 5-fluorouracil. Otherwise, aside that, they do pretty much the same thing. So other options, pterygium excision with beta irradiation, like applying a radioactive substance to the place you removed your pterygium from. So it reduces recurrence and like destroys those abnormal cells that cause this growth. Also, you can do what we call pterygium excision with amniotic membrane transplant. The normal amniotic membrane in O and G, so there are some commercially produced ones, no, not commercially treated ones that you can use. So from that part you remove your pterygium from, you can just cut the amniotic membrane and plaster, more like plastering they place, suture it there, either with suture or even using glue, what we call T-cell glue, and that's it. So you can also do what we call pterygium excision and conjunctiva autograft. What this simply means is that that part you removed your pterygium from, you can remove part of the conjunctiva on the same eye, healthy conjunctiva on the same eye, remove it and plaster it to the place you remove your pterygium from, either using sutures or glue, T-cell glue. And these days, people don't even use suture or even glue anymore. They just create a blood base, more of like at that base that you see, just create some form of little injury that can trigger tiny bleeding. And when it happens like that, you just carry the conjunctiva that you have excised and just plaster it to it. And it takes, you know. So those are the options. Next slide, please. So complications, like I told you, I just described them, conjunctiva autograft. So sometimes you can have what we call graft contraction. That conjunctiva you placed may be contracted, so it causes graft contraction. It may be edematous, graft edema, graft necrosis. If there was no restoration of blood supply, to the conjunctiva that you placed, you may have necrosis. You may have what we call granuloma formation too, one of the exaggerated inflammatory processes. Then excessive cautery can cause scleral necrosis. There may be infection. Still, with all this, mitomycin C, some may still come down with recurrence because, of course, it's not 100% successful. So it's 95%. So that 5% may still be there, having recurrence. There may be corneal scarring and there may be ocular motility restriction, especially for those that form a lot of scars, hypertrophic scars. So even in the eye, just a little injury, the person will just, form excessive fibrous tissue that may cause some restriction of the ocular motility. Next slide. Oh, are we done?
Yes, sir.
All right. So I hope I've been able to impart a little knowledge and not confuse many people.
Thank you, sir. Thank you, sir.
Okay.
Thank you, sir.
Thank you. All right.
Thank you, sir.